Hello, and thank you for checking out FirstcallID, How to Do an Infectious Diseases Consultation. My name is Dr. Paul Bunce, and I'm a specialist in infectious diseases and internal medicine. In this session, we'll be covering the approach to non-resolving skin and soft tissue infections. If you haven't had a chance to do so already, check out our first session on how to do an infectious diseases consultation, which covers a lot of the basics of consultations in general, whereas this session really focuses on the specifics of skin and soft tissue infections. Lastly, before we move forward, just a quick note that this content is for educational purposes only. Please refer to current guidelines and use your own professional judgment in clinical practice. So there's a couple of reasons why we're focusing on non-resolving soft tissue infections in this session. The first is that the vast majority of patients with soft tissue infections are started on similar antimicrobial therapy, usually a first-generation cephalosporin. Mind you, the principles that we cover here will be helpful in assessing patients with soft tissue infections who've yet to be started antibiotics anyways. The second is that ID is much more likely to be consulted in cases where patients are failing to respond to empiric antimicrobial therapy. So this is much more in keeping with what we're going to be seeing as ID consultants. The key components to our assessment include an evaluation and an understanding of their prior episodes of cellulitis. So most patients who have soft tissue infections have a history of prior infections. We want to know the frequency of their infections, any precipitants, the therapy they received and the response to it, as well as any microbiology if it's available. And with the current episode, we want to confirm their current therapy and assess if there's any signs or any evidence of clinical improvement. With soft tissue infections, it's essential to gather an exposure history because the majority of soft tissue infections are caused by organisms that colonize the surface, which is affected by someone's exposure history. We'll evaluate for any signs of complication of infection, so a necrotizing soft tissue infection, abscess, alternative diagnoses, or any evidence of metastatic infection. Our investigations, while we'll almost always include them in our assessment, are of limited value in diagnosing soft tissue infections or complications of infections. And when we provide our recommendations, we'll account for the most likely cause. We want to optimize our therapy, keeping in mind principles of antimicrobial stewardship, optimization of oral antibiotic therapy, and implications for future episodes. We'll also discuss and address prevention to help lower the risk of future episodes of infection. Here's a schematic of the causes or the types of explanations for patients who have a non-resolving soft tissue infection. The first time I was taught this, I thought the teacher was an absolute genius, just framed something so clearly and eloquently. The truth is most ID doctors have a similar framework. And this is just one example. Key points about this. So, when you see a patient with a non-resolving infection, there's often a tendency to go straight to the need or the urge to broaden antimicrobial therapy. So if they're not getting better on cefazolin, switch them to Petazo, add vancomycin. And while adjusting your antimicrobial therapy may be the right step if there's a mismatch between the antibiotic and the causative pathogen, there are many other considerations as well. We need to consider, is there appropriate penetration of the antibiotic to the tissue where the organisms are living? Could there be a complication of the infection? We always have to keep in mind the possibility of an alternative diagnosis. And then the fact that most soft tissue infections will start to get a little bit worse before they get better. And it's often challenging to know at what point have you waited long enough to say that your empiric therapy isn't working. We often expect people to get better the instant we click on the antibiotic on the computer or write the order. And it often takes a little bit of time for things to turn around. Here's a bit more in-depth discussion of the types of examples of each category. When we're assessing the patient, like I said at the beginning, we want to have an understanding of their prior episodes of soft tissue infections. So how often are they occurring? Is there any predisposition or behavioral events that are linked to these episodes? When they do take antimicrobials or are receiving antibiotics, what is their typical response to therapy? Do they often respond quickly? Do they take more time? Do they often need IV antibiotics initially before they start to improve? So it's important to know how they've responded before. And it's important to look back at the microbiology. There's a small proportion of patients who will be concurrently bacteremic with a soft tissue infection, and that can be helpful in guiding our therapy. Recognizing patients' colonization status with something like MRSA is important, but it's also important to recognize that even in patients who are colonized with MRSA, the majority of non-purulent soft tissue infections are still caused by beta hemolytic streptococci, and so you have to take the colonization history with a grain of salt. We'll look at their current antibiotics as well as their response to the therapy. If they're taking the medication at home, have they been taking an adequate dose? Have they been adherent? Have they been keeping the medication down and not vomiting it up? And in hospital, how long have they been on antibiotics? And evaluating for any response to therapy. Now, one of my tricks often when I get a consult for a non-resolving cellulitis is even if I get the consult in the morning, I'll sort of defer seeing it till later in the day because I want to give the most time to see if there is any type of improvement. Now, there's a limitation to our clinical assessment of markers of improvement, but I do my best to see, maybe the leg is a little bit less swollen or a little bit less painful, or the erythema settled down just a little bit. Maybe they've effervesced. Lab parameters we'll look at, but often can be falsely reassuring or might not be an accurate measure of someone's clinical response. Exposure history, as with all ID consultations, is an important component of our assessment, probably more relevant than some other consultations. So in addition to the key identifying data, I usually include my exposure history as part of my just general understanding of the patient's background history. So where were you born? When did you emigrate to this particular country if you were born abroad? What is your occupation? What's your living situation? Thinking about sexual history, substance use, injection drug use, which may predispose to certain pathogens. Also asking about specific exposures. So clearly, do you have any pets? Do you have a cat? Any animal exposures? Have you been in contact with any animals? Any recent travel? And asking about pastimes, hobbies, and activities. And if these are done with others, did anyone else who's engaging in the same activities have anything similar develop? Our examination needs to include not just a visual assessment, but an examination with our hands. We need to feel the skin and the tissue because there are certain findings that are only discernible with palpation. We'll assess for any evidence of clinical improvement. With patients with a soft tissue infection, we always have in the back of our mind the concern for a necrotizing soft tissue infection. Now, there's different resources that I'll highlight parameters or clues to a necrotizing soft tissue infection. For me, things that I specifically look for and will comment upon. So pain out of proportion to the appearance, pain beyond the margins of the erythema, any patches of skin necrosis, or any patches of anesthesia. Also feeling that the texture of the tissue in some types of necrotizing soft tissue infections, the limb will have almost like a wooden type of feeling to it. You might even also feel some crepitus. We'll also palpate for any evidence of fluctuance or abscess. And overall, we'll look for any evidence of systemic manifestations of infection or metastatic foci of infection. Investigations are often of limited value in diagnosing soft tissue infections and distinguishing superficial cellulitis from a more complex infectious syndrome. Imaging is a variable value as well. Some people will want an X-ray or CT scan to assess for subcutaneous air when you're looking for a necrotizing soft tissue infection. I think there are situations where this may be of value. I'll often say, though, if you have a patient where you're concerned about a necrotizing soft tissue infection, the last place I want the sickest person in the hospital is going to medical imaging and going to be stuck in a scanner. And often the assessment for a necrotizing soft tissue infection really can be based on clinical factors more than radiological factors. We'll often do imaging also to assess for evidence of contiguous osteomyelitis in certain cases. We'll document and review the microbiology, blood cultures especially. Superficial swabs are sort of challenging to interpret, I'll say. We have to recognize that a superficial swab will identify organisms living on the surface and not necessarily the organisms that are causing infection, or there might not even be an infection to begin with. And so we have to be mindful when we're performing a swab that it's likely to detect colonizing organisms. If you're able to obtain purulent material, that's a different story, and that can be much more helpful in guiding our therapy. And we'll also not just look at the current microbiology, but reviewing prior microbiology for any potential colonizing organisms, especially if someone's unwell. So if someone has a history of MRSA colonization or multi-drug resistant gram-negative colonization and comes in with a severe soft tissue infection or a life-threatening soft tissue infection, we want to take that information into account. From this information, we'll provide our summary and recommendations. When it is a non-resolving soft tissue infection, rather than list all of the causes, we'll highlight what the most likely causes in this particular patient. As I say, being mindful of stewardship principles, the idea here is that if you start someone on overly broad antibiotic therapy and they improve, we don't know if that's because they needed the broad spectrum therapy or it was just they had something, a typical organism, and they recovered anyways. And the challenge is when you start someone on broad spectrum therapy, it's often difficult to de-escalate their therapy, especially when culture results aren't going to be available. If someone started on vancomycin and they start to get better, and as an ID consultant, I'm asked to switch them to PO options, I'm not sure if they required vancomycin or that coverage for resistant gram-positives, and it's often difficult to have a direct oral step down. Also, in future episodes, if someone's MRSA colonized and they show an improvement in their cellulitis to a first-generation cephalosporin, because they're usually caused by beta hemolytic streptococci, like group A streptococcus, the next time they come to hospital, the clinicians will see, oh, they got better with cefazolin last time or beta-lactam. We can use that this time as our empiric therapy. So there's a little bit of forward thinking when it comes to our management. Lastly, most patients who have a soft tissue infection are at higher risk of future infections. And so being mindful of preventative strategies, and not all of these can be addressed in the acute setting, but when it comes to cellulitis or non-purulent cellulitis, which usually involves the lower extremity, anything you can do to improve the size of the limb and the skin integrity will lower the risk of infection. So I often say, you want that skin to be as soft and smooth as possible and the leg to be as skinny as possible. Whether it's edema or obesity, when it comes to the skin quality, moisturizing the skin, treating tinea pedis if it's present, these are all very helpful. And in rare situations, you can even consider antibiotic prophylaxis. So here are the key points that we've highlighted today. And as I leave you with the summary of these points, I just want to highlight a couple of points. The first is, I've mentioned this already, you cannot evaluate a patient's skin or soft tissue infection with just your eyes. You need to use your hands, right? Feeling for warmth, firmness, fluctuance, or crepitus. Okay. The second is sort of a mantra I've been taught, it is treat the patient, not just the erythema. And so understanding the predisposing factors for soft tissue infections and trying to optimize them. Things like diabetes control, managing peripheral edema, hygiene. If there's a history of injection drug use or other factors that will predispose them to soft tissue infections, try to address these within our capacities or capabilities. Right? Try to understand the context of the patient's infection and not just the bacteria themselves. So, as with many of these topics, there are a lot of very helpful resources available. One of my favorite resources is from a number of years ago. It's called the Narrative Review, Diseases that Masquerade as Infectious Cellulitis. And this is a great, not completely comprehensive, but a great, well-structured review of the types of conditions that can mimic soft tissue infections. And even as a non-dermatologist, I find this is a very helpful guide to come up with some ideas as to why patients might present with something that looks like cellulitis but is not behaving the typical way they would expect to. Two other review articles, Cellulitis, a review, and a more concise review, a 6-year-old woman with recurrent cellulitis, which addresses some of the preventative strategies that we would want to employ as well. So that's all for now. I'm Dr. Paul Bunce. And we wanted to thank you again for watching. Please share any feedback you have about the session or First Call ID as a whole. And if you find this helpful or find it useful, please share it with a friend.